So the title of tonight's talk is Best Practices in Regional Anesthesia, and this is something that came out of the program Kirk just summarized, where we hope to continue to work with the FPAs in this format and continue to provide sort of support and continuing education around regional anesthesia, but just felt that it might be useful to kind of just go back to basics and review just some really basic concepts in regional anesthesia, just to make sure that everybody's on the same page and we're doing things safely as we proceed here. So I apologize in advance if any of this is at too low a level, or it's things that you already know and are doing. I'm sure much of it is, but it'll hopefully just get us all on the same page. Disclosure-wise, Chris nor I have any disclosures in terms of funding sources. We don't receive any money from industry or anything to do this. The objectives for tonight. So I'd like to review what we do at St. Paul's, as well as what's sort of accepted in the community broadly in terms of monitoring standards. Then I'd like to talk about just sort of a suite of things that we can incorporate into our regional anesthesia practice to reduce the risk of nerve injury. Then we'll move on and talk a bit about, kind of just review the topic of local anesthetic systemic toxicity. And then we'll talk a bit about kind of what we do at St. Paul's in terms of aftercare for our patients, when they're going home, particularly for same-day cases or ambulatory cases. And then we'll talk a bit about our follow-up as well, in terms of how we follow patients up after regional blocks, and what we might do if something concerning is detected on follow-up. So first of all, monitoring standards. So the reality is there's very little in terms of specific guidelines or recommendations specific to regional anesthesia. So we sort of just apply the general CIS standards to what we do. And at St. Paul's, we use standard CIS monitoring during all of our regional anesthetic techniques. So that's an ECG, non-invasive blood pressure, and pulse oximetry. And we extend that monitoring window for at least 30 minutes post-injection. Now I recognize that very, very few of those on the call tonight likely have the luxury of a block room like we do. So you may be doing your blocks in the operating room where the surgery will occur, or you're doing them in the PACU. But I thought it was worthwhile to just mention our monitoring interval as well, because the way it works in our hospital is we'll do the block, and then the patient will just linger in the block room for until the room's ready for them, essentially, and we monitor them continuously for at least 30 minutes. And just basic, good housekeeping things. We want to ensure we have resuscitation equipment immediately available. So we want to be prepared to manage an airway. We want to have access to typical anesthetic drug cart with our usual resuscitation drugs. We want to have a local anesthetic systemic toxicity resuscitation kit as well, because should this complication occur, that's probably not the time to be scrambling to try to find where to get intralipid from the hospital pharmacy, for example. So it's worth preparing ahead of time. And also the crash cart, which should be ubiquitous wherever we're providing anesthetic. So prior to doing our blocks, we do a timeout procedure. And now our block room can get quite hectic and busy. Some days we might be doing 12, 14, 16 blocks in a day. So the chance of an error occurring is potentially higher in that situation. If you're just dealing with one operating room list and one patient, maybe it's less likely, but nonetheless, it's probably a good habit to be in. So what we do at St. Paul's is we do a timeout before starting the block. So this is kind of when the patient's in the bed, their IV has been started, they're on monitors, we've got our block kit prepared, we're all ready to go. And before we put on our sterile gloves and begin, we'll do a timeout. So we confirm their ID, next to the surgical consent. We'll confirm the surgery plan, and specifically the site, if it's a limb or extremity surgery, as many of these will be. We just double check that they do have a functional IV and that we have monitors applied. Review any allergies, and then specifically review any current or recent use of anticoagulants or antiplatelets that might influence the appropriateness of the block we're about to do. And we always ensure that the patient's engaged in this process as well. So we invite them to participate, and we typically try to do this before any sedation's administered. Okay, so how do we reduce the risk of nerve injury? So this is one of the sort of feared complications of regional anesthesia. We don't want to see nerve injury. It's a rare risk. It can happen, but there is certainly things within our control to reduce the risks. So first of all, how does it occur? Well, it's a complex topic. It's beyond the scope of what we intend to do tonight. But if, on a basic level, there's multifactorial ways that a nerve injury can occur in the setting of a regional anesthetic block. So it may be a direct traumatic injury. So this is needle trauma or injecting medication under high pressure in close proximity or within a nerve. It may be an ischemic injury or a vascular injury of some sort, secondary to the block we've done. Maybe a chemical injury, and fundamentally local anesthetics are neurotoxins. We just use them in a controlled dose and an appropriate dose, but a chemical or injury could occur. Could be a surgical injury, could be secondary to a prolonged tourniquet time, direct surgical trauma to the area. This, as Chris will allude to, being our division chief for this, and it's he's tasked with sorting a lot of these out afterwards. It can be really tricky to suss out, really what caused what, and it's important to just be collaborative and work together collaboratively with our surgeons to investigate these when they do pop up. It could be a secondary injury. So this is something that happens as a consequence of the block we've done, but it's not directly related to the block. So here I'm thinking of, perhaps we do a lower extremity block and somebody has a numb foot and they go home after surgery and they just allow that foot to dangle down, off a chair for many hours, and they get excessive edema and swelling, and their cast becomes too tight and they get an injury because of that. So that's, the block contributed to what happened, but it didn't necessarily cause, the injury. So that's a secondary injury. So to hopefully reduce, particularly the first one, so traumatic injuries, as well as a few of these others, we kind of advocate for a suite of best practices to ensure optimal safety. So we recommend the use of routine use of ultrasound. We recommend using the patient as a monitor, and I'm going to elaborate what I mean by each of these in a subsequent slide. We advocate using a purpose-designed regional anesthetic block needle for most of your blocks. We want to avoid injecting things under high pressure. And we can, in fact, dust off the nerve stimulator and use that as another tool to sort of give us a bit of additional information about, the possibility that our needle may be too close or within the nerve prior to injecting. So ultrasound. So if you go to a regional anesthesia meeting, the regional anesthesia nerds will debate back and forth whether, there's any evidence that ultrasound actually reduces the risk of nerve injury. And it's a difficult thing to study. In this day and age, it's more or less standard of care for most of our blocks. So it's potentially unethical, or it's difficult to achieve equipoise in randomizing patients to, a non-ultrasound guided technique when that's sort of the standard of care. So for a lot of reasons, the evidence is going to be difficult to find. But I think, from a common sense, pragmatic point of view, most of us would recognize that if we can sort of see the anatomy in real time and see the needle, moving within the tissues, that, that inherently should increase safety as well as efficacy of what we're doing. Using the patient as a monitor. So certainly if we're, putting a needle in and attempting to do a block and a patient's experiencing paresthesias or, severe pain, that should be a sign to reposition the needle or reevaluate what we're doing before proceeding any further, before injecting a volume of medication. I do typically prompt patients, during a block and say, and just pose it in these terms. So I'll say something along the lines of, as we go here, you may experience a little tingle or like the sensation somebody's tapped your funny bone, for example. That can be normal as the needle brushes up against the nerves. If you do experience that, let us know, because we would want to know about that. That can be a sign, that we should reposition the needle slightly. So I don't try to convey that it's necessarily a harmful thing, but I also want to, sort of indicate to the patient that it's important that they communicate that to us and not just sort of sit there stoically. Sedation may improve the patient experience, but we want to most of the time avoid heavy sedation or blocks under general anesthetic, with the exception of special cases. So sometimes that may be in the patient's best interests, and I think just a more detailed consent discussions, the next step in that. But in general, most of our blocks we're doing on awake or lightly sedated patients. We want to use a purpose-made block needle. So a block needle, there's a variety of manufacturers that will market these products. You can experiment them and see what you like best. But in general terms, a block needle is going to be a short beveled needle, so it's somewhat blunted, in contrast to a long beveled sharp cutting needle. So it's less likely to, sort of cut fascicles of nerves in the event that you get, the needle intraneurally, more likely to kind of push them aside. But bench research has shown that short beveled needles can cause, in fact, more extensive kind of blunt trauma if you do forcefully impale nerves with them in an experimental setting. Most of the time, we're going to not be doing that clinically, but it's kind of like that, larger gauge slug bullet or whatever might, actually cause more damage than a sharper bullet. And oftentimes purpose-made block needles are more echogenic as well, so that may assist with your, with your needle tracking as you do your blocks. Injection pressure monitoring. So we're a bit lackadaisical about this in our block room, in fact, and it's something that, we've talked about at times whether we should clean up our act a little bit, but at present time, we sort of abide by this hands-feel technique, and we know from research that that's actually not really all that sensitive, but we do rely on our assistants who are generally anesthetic assistants in our block room to kind of tell us if it's tight to inject or if, it's not, if the pressure is high. But we recognize that's not terribly sensitive. Now, there is products such as these luminometers available that that can give you an indication if the injection pressure is high. We don't use those in our block room, but arguably we should consider getting something like that as well to just improve our safety. I don't think they're terribly expensive. And lastly, the nerve stimulator. So in this case, we're not using the nerve stimulator specifically to, help us find the nerve. We already can see the nerve on ultrasound. We're using it to kind of tell us that we're not too close. And so what the science recommends here is kind of putting the needle where you think it should be. But before injecting, put some current on through your nerve stimulator. And if you're eliciting a motor response, or if it's a sensory only nerve like the saphenous nerve, if you're eliciting a sensory response at or below 0.5 milliamps, that might be an indicator that your needle's too close and you might want to reposition the needle somewhat. And certainly if you're getting a response at sort of 0.2 milliamps, which would be a very low amount of current, that should really be a warning sign that, okay, there's a high chance my needle's too close. It may be intraneural. I should, back out a little bit before injecting any medication. Of course, the reality is no single thing can, absolutely prevent this from occurring. But when we use these things kind of together as a suite, I think then we're, really doing kind of the best we can from multiple angles to ensure the incidence is as low as we can make it of nerve injury. So here's just a little algorithm I pulled from NYSORA. I don't have any particular professional connection or association with NYSORA, but I do find it to be one of the better resources out there in terms of, they keep their website quite current. They have a lot of really, really good articles by experts in the field. So, if you are looking to learn more about regional anesthesia, NYSORA is a good place to start for web resources. And this is kind of their algorithm as to how to use the nerve stimulator. It's a bit busy, so maybe just something you kind of work through on your own after the talk if you're interested. So here's how we set up for a standard block, single shot block. So what we'll typically do is we have our sterile gloves. We'll position the patient, expose the site that we're interested in. We'll open up our gloves, and then on the sterile paper, as you open your gloves before you don them, we'll just open up a sterile ultrasound gel, the intended block needle, 5 cc syringe, sharp 25 needle for skin infiltration, and a blunt fill needle to draw up some lidocaine. Then we'll open a 5 ml vial of lidocaine on the bench as well. And we'll prep the skin with 2% chlorhexidine, don our gloves, and then proceed with the block accordingly. For our continuous catheter techniques, we get a bit more elaborate in the sterile setup. We do typically wear a sterile gown, and we use much more extensive draping because those catheters may remain in the patient for 5 or 7 days even, so the risk of infection is definitely much higher. With a single shot block, we want to be clean and sterile, but the risk of infection is quite a bit lower than a continuous catheter. Okay, so local anesthetic toxicity. So from my point of view, whenever I don't know what Chris would say or what others would think, but when I'm assigned to the regional role on our rota, as I ride my bike into work every day, this is kind of what goes through my mind. And I just think, I hope today is not the day that I have a serious last event, because this can be, a very frightening and devastating complication of the regional blocks we do, but we should be able to prevent it in most cases. My phone is ringing. So first of all, we'll talk about the risk factors. We'll talk about how we prevent it. We'll talk about maximal doses of local anesthetics, just review that. We'll talk about how it may present, and then the resuscitation of it. And then I'll show you what our last kit looks like on our block carts. So first of all, risk factors. So it's kind of the extremes of age. It's our pediatric patients or it's our elderly patients. And in fact, the most latest review on this would identify 60, which is pretty young still. But I kind of certainly think about it in the context of our frail elderly patients, like pictured here. Low muscle mass and low body weight are both risk factors for it. Seems to be a bit more common in female versus male patients, and that may just be a factor of the lower muscle mass and body weight typically found there. Certain comorbidities, so cardiac disease, particularly any arrhythmias or conduction abnormalities, is a risk factor. Local anesthetics are largely metabolized by the liver, so somebody with very impaired liver function, that should be a consideration. Different metabolic diseases, many of these are quite rare and unusual, so it'd be unlikely to be encountering these regularly. Certain CNS diseases, and somebody with a pre-existing seizure disorder, for example, may be more predisposed to a CNS presentation of local anesthetic toxicity. Low plasma protein binding states. So this is, again, your liver disease patients, your serious malnutrition, infants, pregnant patients. The last events do unfortunately occur secondary to labor epidurals and epidurals being used for C-section on occasion. This does comprise some of the evidence. The local anesthetic chosen plays a big role. So bupivacaine and ropivacaine being certainly much more cardiotoxic than lidocaine, and lidocaine more associated with CNS toxicity. The block site, or where you inject the medication, plays a role, and certainly more vascular sites that have higher uptake may be more associated with this complication. Seems to be also associated with prolonged local anesthetic infusion. So if you've got a labor epidural that's running for many hours, or your continuous perineural block for several days, this would also be a setting where it may occur. So how do we prevent it? So ultrasound. So according to regional anesthesia pain medicine, the kind of comprehensive guidelines about LAST and its identification and treatment, they do recommend ultrasound guidance, and this is just really to avoid intravascular injection. Goes without saying, but we want to use the lowest effective dose to achieve the clinical endpoint we're looking for, and avoid using an overdose of local anesthetic. We want to use an incremental injection technique. So for us, when we have the needle placed where we think it looks good on ultrasound and we want to begin giving the medication, we'll first aspirate the syringe and ensure no blood returns. And then we'll give a small aliquot and just assess the spread on ultrasound and think, can we see where the medication is going? Does it look like what we expect? And then we inject in sort of 3 to 5 ml aliquots and then aspirate in between. And certainly anytime you reposition the needle mid-block, if you decide, okay, I want a bit more local anesthetic on this aspect of the plexus, then again, we're going to repeat this procedure and aspirate and ensure that we aren't in a blood vessel inadvertently. The use of epinephrine in blocks, so as an intravascular marker, is recommended by the authors of the sort of comprehensive guidelines here. I must say that we don't use it all the time at St. Paul. Certain blocks that we identify as higher risk, that we are using a larger volume of local anesthetic, we will use some epinephrine in the blocks, but not for all our blocks by any means. And so they say it's open to physician judgment, and this would be something that Chris or I would be happy to give you our thoughts on afterwards, just if you have a specific technique in mind, what you might do. And we want to be aware of the additive nature of local anesthetic. So if we're doing a block and the surgeon is also infiltrating local anesthetic, and if we're giving lidocaine as part of our induction, through the IV or using a lidocaine infusion, we should always, take that into consideration, that these are additive. Okay, so maximum doses is just pulled from Miller, so I won't belabor it, but lidocaine 5 per kilo with a plain solution, 7 per kilo with epinephrine. Bupivacaine and ropivacaine, for me personally, I just keep it simple when I'm working, as well as working with trainees, and I just say 2.5 plain and 3 milligrams per kilogram with epinephrine. Just possibly you could get away with a little bit more ropivacaine, but for the most part, I kind of adhere to just 2.5 milligrams per kilogram plain and 3 milligrams per kilogram with epinephrine, just to keep it simple. All right. So how does LAST present? So classical early signs would include sort of CNS excitement, so the patient may become tremulous, or you may sort of see early clonic activity or seizure-like activity. They may complain of metallic taste in the mouth or perioral numbness, tinnitus, dizziness, drowsiness, any sort of altered mental state, could be a sign of this. Cardiovascular signs, could include any bradyarrhythmias, hypotension, any new conduction system delays. If you note that the QRS is widening on the ECG, that would obviously be worrisome, or it may present with sudden cardiac collapse and cardiac arrest in sort of a worst case scenario. This is just meant to show that the presentation is quite variable. There's no sort of textbook cookie cutter presentation that is going to happen when you have a LAST. It can be arrhythmias, it can be cardiac arrest, it can be bradycardia, it can be CNS signs with cardiovascular signs or without. It can be cardiovascular signs alone with no mental status changes. So the point of this is really just to show that if you're doing a block and something seems abnormal, LAST should be immediately coming to mind as a possibility. So again, variable. Delayed presentations are becoming increasingly common, and authors hypothesize this is maybe related to the increasing use of ultrasound is kind of diminishing those initial intravascular injections, which would be kind of that immediate presentation of LAST. And so now those are less common and happening less because of ultrasound. And now we may be seeing more delayed presentations, where the medication may have been given in the right spot, but maybe just an overdose has been given and it's absorbed and they develop LAST in a delayed fashion. Also, the rising popularity of interfascial plane techniques such as TAP blocks or PEX blocks, ESB blocks. Some of these techniques are kind of dependent on a larger volume of local anesthetic being administered in order to be effective. So clinicians may be more likely to give a larger total dose of local anesthetic. So that may be maybe an explanation why those particular techniques seem to be associated with a higher incidence of this. And again, currently we monitor for 30 minutes at least post-injection, with this in mind. So how do we treat it? So, this is, a true LAST with cardiovascular signs is a dire emergency. This is a code blue in your hospital. You're needing some, help immediately at the bedside to manage this. The basic principles are we want to, avoid acidosis and hypercapnia as well as hypoxia, which worsen this problem. They exacerbate what's happening. So we want to manage the airway early. And then intralipid is kind of, particularly for cardiac toxicity, is kind of the first line treatment here. So we want to give 1.5 mils per kilo, or if it's a normal sized adult, 70 kilos and above, you can even just start with 100 mils to keep it simple. And then we want to start an infusion. 0.25 mils per kilo per minute is what's recommended. And if things aren't going well and the resuscitation is not proving to be successful, we can repeat the bolus and we can increase the infusion as well. The upper limit of how much intralipid you can give in this setting is high. It's like, I think 12 milligrams per kilo or something. So it's like multiple bags sort of thing. And, the reality is that we're just going to continue going until we get some return to spontaneous circulation. Propofol is not a substitute for intralipid. They do share some commonalities in terms of the emulsion, but that's just going to make a bad situation worse. So please don't use propofol here. And if it's an isolated CNS toxicity, benzodiazepines would be the first line to blunt or abort a seizure. But small doses of propofol may be considered as well, if hemodynamics are preserved and stable. Okay, and then the rest of ACLS applies. CPR should proceed immediately if there is PEA or some other malignant dysrhythmia. Reduced doses of epinephrine are recommended because this is a situation that often devolves into a malignant arrhythmias like VFib or VTAC. And so we don't want to make that worse with giving too much epinephrine. So the guidelines recommend less than a mic per kilo. Vasopressin doesn't seem to play a role here, wouldn't reach for that. We want to avoid any other channel blocking agents. So your calcium channel blockers, beta blockers, or additional local anesthetics are not going to be helpful. But amiodarone is acceptable for ventricular arrhythmia here, and you shouldn't hesitate to give that. And this likely not an option for many of the audience here, but if you are in a center or nearby to a center with cardiopulmonary bypass or ECMO capabilities, an early phone call to that team is also recommended here, because there have been some good saves with ECMO institution in serious last events that have had good outcomes. But that's going to be tough if you're in Revelstoke or something, I'm sure. I would recommend just going to ASRA's website, and I think you can pull this off for free, and maybe just printing it out and laminating it and sticking it on your block card or your anesthetic card, because if this were to occur, it's probably not the time to be trying to remember this stuff. So they have a pretty good algorithm for for basically covering everything I've just said. And similarly, NYSORA has something similar as well. If you preferred the the look of their image, it's the same information. In the interest of time, I'll maybe just skip over the mechanism of how last resuscitation with lipid is thought to work. It's it's kind of esoteric. We'll just get on to what's more relevant. So here's our local anesthetic toxicity kit that sits in the bottom drawer of our block carts at St. Paul's and at our sister hospital, Mount St. Joe's. So in it, we have two 250 ml bags of 20% intralipid. We actually have 2 vials of midazolam as well. So if the provider happened to not have midazolam with them, they would find some in the cart. We have a few syringes and a few blunt film needles. This is a 60 ml syringe. I don't think we actually have that algorithm printed out in our kit, which we maybe should consider doing that just in the heat of the moment. I can see how you might forget the dose of intralipid, so might talk to our division head and see if he's interested in that. Okay, that's enough about last. I hope to never see it, but we want to be prepared if it is to occur. What about aftercare? So for our patients going home after they've had a block and they're having their ambulatory surgery, we provide them some basic information. And the truth is the nurses do most of this for us, but I do try to reinforce a few of these key concepts with the patient myself. So we want to emphasize the importance of caring for the insensate limb, and obviously they need to be provided a sling or a boot or whatever to protect the limb while it's insensate. I really try to emphasize the importance of elevating the operative site whenever possible, and I put it on the patient and explain to them the rationale, and I just talk about swelling and edema and how those impair healing, and they're likely to contribute to a worse outcome from their surgery, and just kind of reinforce the importance of elevating the limb. And then I recommend to them to assess the extremity as well for basic things. Does the cast or the dressing seem too tight? Can they slip a finger in between the cast and their skin? If not, that might be a sign it's too tight. Just basic things like that. Make it very clear that unsupported ambulation, if they've had a lower extremity block, like a femoral nerve block or sciatic nerve block, and probably even a saphenous nerve block, absolutely can't happen, because the chance of a fall. We don't want to hear about anybody having a fall at home or in the parking lot. So I do try to be quite clear about that, and the nurses are also quite attentive to that. We advise against the use of any ice or heat while the limb's insensate. We don't want somebody to sustain a thermal injury or a frostbite injury, but after the block's worn off, it's whatever their surgeon recommends is okay by us. And I emphasize a multimodal analgesic regimen whenever applicable. So that might be your acetaminophen, NSAIDs if appropriate, whatever the surgeon has prescribed in terms of opioid analgesics or otherwise. And what we want to avoid is kind of this situation. So severe rebound pain or a pain crisis at the time as the block resolves or wears off is unfortunately not rare. It happens relatively frequently, and sometimes it's unavoidable. There's just very little we can do to avoid this. It's just the way it's going to go. But sometimes there is things we can do to at least mitigate or reduce this somewhat. So I think patient education, and particularly expectation setting, is really important. So if I'm concerned somebody's at risk for this, I do try to have a pretty frank conversation with them at the time as we do the block, and just make sure that we set realistic expectations and let them know, when the numbness wears off, like, your wrist is going to hurt. That's normal. Like, we expect it to hurt. Be prepared for that. And a few things you can do to reduce how much it hurts might be taking your pain medications early, keeping the limb elevated, all of those kind of things. And I think that just setting that expectation is the first step to avoiding this being really problematic. Secondly, I think thoughtful provision of the blocks that we do, and that may in some cases mean we choose not to do the block. If somebody seems like they're going to really struggle to follow basic instructions, or they're not very reliable for reaching them for follow-up and that type of thing, that may be somebody who's better served without a block. And an alternate anesthetic, general anesthetic, or neuraxial technique, and then manage their pain conventionally in the PAR or PACU before they go home. I also try to choose local anesthetics to avoid the block wearing off at 2 or 3 o'clock in the morning. I think that's another situation that sets the patient up for dysfunctional postoperative acute pain. People are much more prepared and able to manage an increase in their pain if it's a normal waking hour. If it's 2 o'clock in the morning, nobody is really firing on all cylinders at that time, and it's not a great time to have your pain crisis. The use of IV adjuvants like dexamethasone or dexmedetomidine certainly have a role in prolonging the block, as well as potentially adding their own analgesic effects. It's a broader topic that we may cover in a future session, but suffice to say that it's worth reading about a little bit, and just checking out some of the evidence there for yourself, and whether you want to incorporate those at all. At the present time at St. Paul's, we're not using these directly in the block. We're using them through the IV in appropriate situations, but we're not using either of these adjuvants through the perineural route. So that's, I think, the end of what I wanted to say. And we have just a few more slides, and Chris is going to talk a little bit about some of the follow-up that we do, and sort of how we assess patients after a block if anything pops up on follow-up. So I'll maybe hand it over to Chris, and if you just want to tell me when you want to advance the slide, I'll just do that for you, Chris.
Thanks, Steve. So as part of our program, we do endeavor to follow up on all of the patients roughly 2 days after they've had their nerve block via telephone. And that's just to ensure that, mainly that we have not had any issues with post-op neurologic injury, which Steve mentioned we want to avoid at all costs. And I've got there that some of the red flags that we look for include any ongoing motor deficit or prolonged block. If they have ongoing severe or neuropathic quality to their pain, that can be a sign of some degree of nerve injury. And it's a little bit different than the rebound pain that Steve was just alluding to as the block wears off. Oftentimes, or commonly, I would say probably 30 to 40% of the time, for in particular orthopedic surgery, patients can have a significant amount of pain as the block wears off. But once they have a handle on their multimodal analgesia, that pain gets under control in a reasonable fashion. Ongoing severe neuropathic pain may be a sign, and I have seen maybe 1 or 2 cases of this, of nerve injury, and we would want to know about that relatively quickly. And any progressive deficit. So if anything, the block should be resolving, and we shouldn't be seeing more density to the block, or motor function that has recovered but then is lost again. So those would be the 3 major red flags that I'd be looking at on follow-up. And I'll show you one of our follow-up sheets so you can see what we ask our patients. Aside from those red flags, getting a sense of their pain trajectory can be important in terms of potentially diagnosing complex regional pain syndrome, which can happen after surgery. Some studies suggest an incidence of 4% or even higher. And after trauma, such as a fracture of the radius or ankle fractures, it can be in the 10% range. We don't tend to see those numbers with our patients, but it is something to keep in mind as we see how the patients do with their pain. And then the final thing that we want to look for, if there are any ongoing concerns, the main thing that we see in our follow-up are paresthesias, which are common and should be treated initially with reassurance. Other less common things could be issues with the block insertion site. We've seen sort of hematomas that have developed there, or pain issues at the insertion site as opposed to where the nerves are blocked. In terms of the timing, we tend to call our patients approximately 2 to 3 days after the nerve block. If we call them a day after the block, it tends to be that there are a number of patients who may have residual block, and so it's difficult to assess them at that time. So a little bit later on, depending on how things could work for you. At our center, we have a resident and a fellow in our block room routinely, so they help with calling. But between the staff person, the resident, and the fellow, we try and call all of our patients. Where I did my fellowship at Dalhousie, there were 2 nurses who routinely called the patients. And at Vancouver General, it was the anesthesia assistants who called the patients. So if you were interested in developing a follow-up program, you'd have to see what worked well for you. I presume it might be the practitioner or a group of practitioners that routinely would do this follow-up work. Feel free to move ahead there, Steve. There we go. So this is actually our record of the actual block. So the procedure note that we do at St. Paul's, we've recently, well, it's been about coming up on 2 years actually that we've had an electronic medical record. And so we had to transition from pre-printed orders and tick boxes that we used to use to drop-down menus and little areas where we can fill in spaces. So you can see at the top, we have the contact information. Oh, actually, this is the, can you go back? Sorry, Steve.
Sorry, I just realized I might have went ahead too.
Yeah.
Seems like a really delayed. There we go. Here we are. I'm so sorry. Yeah, my computer was kind of froze a little bit briefly there. Carry on, Chris.
Okay. So this is the procedure note that we have. We have a number of boxes that get pre-populated by the computer system, which is handy. So we have the surgery, the surgeon, the date of the procedure, risks that we have discussed, and any contraindications. And then we can have a drop-down menu for who performed the block, what needle was used, that we had a timeout, and the specific block and local anesthetic that was used. And then we have free-form text that you can add to with respect to comments or complications. And finally, a post-op follow-up discussion with the patient's phone number there. And then 2 days later, when we're calling the patients, we can add an addendum to this note so that it's all contained within one note. When we were using pre-printed orders, we would have one sheet that the top half would be the procedure note, the bottom half would be the follow-up note. And then Steve, if you wouldn't mind moving forward. So this is the follow-up record that we would fill out. And you can see that we have the timing of when the block wore off, how it resolved in terms of movement, sensation, pain. And sometimes that can be challenging and difficult for the patients to specifically say. And so we're just looking for a general time just to ensure that things have resolved appropriately. We also have a section for how the pain management went, what the pain score was when the block wore off. Was it tolerable or intolerable? It's interesting. Some patients will say they have 7, 8, 9 out of 10 severity of pain, but would say that the pain was tolerable with the medications that they were prescribed and that they took. We see if there were any interventions in terms of the need to contact their surgeon or their family doc, whether they needed to go to the emergency department. And it's not that infrequent that a patient would need to go to the emergency department because of the pain. And then the final final part of the follow-up would be about any ongoing issues. So is there any ongoing motor weakness? Is there any ongoing paresthesia despite return of some sensation? And if there is, then we will follow that appropriately. You can go ahead there, Steve. Okay, so just as to give you a sense of what our follow-up has revealed, transient postoperative neurologic symptoms, these are paresthesias, changed altered sensation that may happen after a nerve block and surgery. It's on a range of 10 to 15%. So because of that, I routinely tell patients that this is common, that this happens after surgery and a nerve block may last for a couple of days, upwards of a couple of weeks, but most of the time by the 1 week out, I'd say 90 to 95% of the time, the paresthesias have worn off. There is, we found a difference between upper extremity and lower extremity. Upper extremity blocks are on the order of 10%. Lower extremity blocks are on the order of 15%. And this is probably due to the fact that lower extremity surgery, so foot and ankle surgery, in and of itself has a higher incidence of post-op neurologic symptoms and nerve injury. And some studies have quoted incidences of 5 to 10% in terms of neurologic symptoms and 1 to 2% in terms of nerve injury. In terms of the prolonged neurologic symptoms, that's much rarer, 1 to 300, and really over the last couple of years, I would say 1 in 1 in 1,000. The rare prolonged motor deficit due to regional anesthesia is quite rare. We've seen maybe 1 or 2 of those over the last 8 years, and that's in the order of 1 in 5,000 to 1 in 6,000. And what's interesting is that our numbers are relatively similar to a large database that was published just in 2020 in RAPM, if you wouldn't mind moving ahead one, Steve. This is out of U of T, the Toronto Western Hospital, where they do a robust amount of regional anesthesia clinical work as well as research work. Vincent Chan is one of the authors of this paper, and he's in some ways thought to be the father of ultrasound-guided regional anesthesia. And you can see the transient neurologic symptoms, their incidence is about 14%, so just around what we've found. Prolonged symptoms, 0.1%, and prolonged neurologic symptoms related to regional anesthesia, about the same, 1 in 5,000. In terms of the prolonged neurologic symptoms, we'll go into what the management would be of those as we, if you wouldn't mind moving ahead there, Steve. Maybe one more, there we go. Okay, so we'll just start, this figure was published in that same paper from the Toronto Western group. And if we start on the right-hand side, if you wouldn't mind just clicking forward, Steve, the sensory deficit only. The vast majority, in fact, I've never seen a quote unquote severe sensory deficit. Most of the time, it's a mild paresthesia where reassurance that this is going to resolve is all that's needed for the first period of time. If it's quite prolonged, then we would have the patient come in for an assessment and potentially a referral for neurologic assessment. If you move forward, Steve, the second component we talked a little bit about, that's the severe neuropathic pain. Again, we tend to treat that, at least initially, in the same category as the paresthesia, unless it's quite severe. I've only had one case where a patient had very severe plantar neuropathic pain after foot and ankle arthroscopic surgery. And because of the severity of the neuropathic pain, we had the patient come in urgently and had a neurologic assessment done, which found entrapment of the tibial nerve at the tarsal tunnel. And so the patient needed a surgical decompression. Most of the time, the pain is manageable, and we can assess whether this is at the probably 4-week component duration, whether this is potentially CRPS, in which case we've referred to our chronic pain colleagues for further assessment and management, or whether this is more in keeping with a potential nerve injury, in which case we would refer to neurology. And then finally, probably the rarest of them all are the significant motor deficits, where we would want to assess that more urgently. And you can move forward again, Steve. So this is just a summary of how we follow up our patients. So if it's paresthesia only or mild neuropathic pain, reassurance, follow them. Initially, we'd probably call them the week after, and I find that probably 90% of patients have a resolution in their paresthesia, have control of their pain management by that point. If there's no improvement at that point, I try to call them every couple of weeks up to the 4 to 6 week mark, at which point I would be in contact with the person who's done the block and organize an in-person assessment. And then if there's still no improvement, by about the 2-month mark, depending on how the patient is feeling, the severity of the paresthesia, we could arrange for a referral for neurologic assessment for conduction studies. The helpful thing about the nerve conduction studies is that they help identify where the potential site of lesion is. I'd say about 2/3 of the time, we find that despite the paresthesia potentially being even radiating up above the level of the surgery, that the site of the lesion is usually surgical. And maybe about 1/3 of the time, it may be related to the block. The other helpful thing about nerve conduction studies is that they can tell you the potential improvement timeline, whether there was a demyelinative or axonal injury, in which case if it's an axonal injury, it may be a prolonged time to recovery, 1 to 2 years even, whereas if it's just demyelinative, it can recover at a sooner duration. If there's either an initial motor deficit or ongoing severe neuropathic pain, we want to see those patients immediately. I'll often get in touch with the surgeon to let them know and have the patient come in either that day or the next day to be assessed in person. Sometimes these patients are admitted, and oftentimes we'll have a nerve block catheter if they're admitted, but if they're having ongoing severe pain, the acute pain service who follows them often talks to the surgical team about splitting the cast or splitting open the splint in order to relieve some of the potential compressive aspects that may be contributing to the pain. And then we would consider potentially urgent imaging to rule out any sort of compression that might be going on from potentially a hematoma or other surgical issue, or potentially getting nerve conduction studies on an urgent basis. And as I mentioned before, we had one case where surgical decompression was needed to relieve the severe pain. So I don't go through this to scare you out of doing regional anesthesia, because there are so many benefits to doing it. But I think that there is a value in providing follow-up for patients who we do provide regional anesthesia for. And over the years of doing this, and I'm sure Steve would agree, it's very educational to know how patients do after surgery and how we can improve our teaching for future patients. And the patients appreciate the follow-up phone calls, and oftentimes if they haven't had any issue at all, they're happy to tell us how well they were treated at St. Paul's, and that's always gratifying to hear. But we learn from those calls, and I would encourage you to incorporate some aspect of follow-up in providing regional anesthesia.
Yeah, we've kind of reached the end of what we had planned to say. It went a little bit longer, but we did start a few minutes late. I'd like to just open up the field to any questions, comments that you may have on any of the content or otherwise.